All right, good evening, everyone. Appreciate everyone joining us today. We're doing this month's webinar a bit differently. We're not going to have slides. It's just going to be a conversation between myself and Dr. Tim Keenan. Tim's a direct primary care physician who works directly across the street from us in our office here in Stratham, New Hampshire. And I know Tim because he used to work with my wife at Core Physicians, which is also across the street, a family practice that is a subsidiary of Beth Israel. And in this fall, he left that organization to join a direct primary care practice, which is the primary topic of our conversation tonight. Direct primary care is a relatively new and emerging field that could potentially benefit people that might not know about it, and that's why we're having Tim on tonight. He practices here in New Hampshire, but we'll be talking about direct primary care, also known as concierge medicine generally, because I know that we have people from around the country listening to this. And if you have any questions during the webinar, please feel free to drop them in the Q&A or chat, and we'll definitely get to those. All right, so Tim, I know you again because of your relationship with my wife, having worked with her for a few years, and you've been in this business for 25 years. You've been a doctor, and as I mentioned, you recently transitioned to direct primary care. So could you just tell us, what you did for 25 years, how your career progressed, and then why you made the decision to transition to direct primary care. And then after that, if you could just give us everyone an idea of what direct primary care slash concierge medicine is and how it differs and complements the traditional healthcare model.
Thanks, John. First of all, I want to thank you for having me. It's a very interesting topic and it's emerging. It's been around for decades, but it's becoming a little bit more common. In certain areas, it's more common than others. I know in some of the bigger cities area, New York City, Miami, it's probably been around for 20, 30 years or more, but it is starting to pick up steam, so to speak. So where I came to it from this, I finished my residency in family medicine in the year 2000, and I practiced in a small town in Massachusetts for 6 years, which was a lot of fun, challenging small town because we truly were the doc that did everything from circumcisions on babies and rounding on babies in the hospital to working in the nursing homes and the intensive care unit and sort of everywhere in between. I came here to Stratham, New Hampshire in 2006 and worked with one of the local hospital multi-specialty groups for 19 years before venturing out to do what I'm doing now. And now it's been about 5 months. And the reasons I really liked the organization that I worked for, and I've had, including John's wife, I had a lot of fantastic coworkers that I really like to be with. The It became very challenging and is very challenging for just about all primary care providers out there as far as practicing with, in order to really be in the black for practicing as far as financially, you have to see a lot of patients and you have limited amount of time and things are becoming more complex. People are living longer, they're on more medications, and people are taking more charge of their health, which is a good thing. They might go out and obtain laboratory tests on their own, and they may email you and call you and have more questions about their care. And as they get older and on more complex medicines and conditions, they need more overall care. So the days are getting longer, but the visits aren't getting longer. So, and the amount of medicine and the amount of information that you're trying to tackle in those short visits is becoming more and more difficult. So you either spend as much time as you can with a patient and answer every one of their questions, and then you're 30 minutes late for the people in your waiting room, or you kind of keep the visit short and say, we can only handle two of your questions today, then you need to come back and then remain on time, or you make your visits longer and you have to shut your doors because financially you can't keep the lights on. So it's sort of an impossible type situation. And a lot of that, a lot of people are very successful at it, first of all, and many of you have fantastic providers. The where I wanted to try something different is within the direct primary care and taking insurance out of the picture is I'm able to spend a lot more time with patients. For example, my physicals are an hour long and most of my follow visits are an hour long. And if somebody comes in for just a quick sick visit, that might be 30 minutes. Whereas before I had half that time for various amount of visits. So it lets us get to do more questions and get to people's concerns. And if because we have a much smaller panel, if we don't get to everything, I can say I'll call somebody tonight, or I can see you tomorrow, or I can see you next week. Today, I'll probably be able to leave after this meeting having answered every question that patients brought to me today, every phone call, every email, and that was not possible in my former type of work. So we keep typically with the direct primary care models, it's a much smaller panel. It is instead of anywhere between 1,200 and 2,000 patients per provider. Uh, these type of models, you'll see anywhere from 300, maybe even as low as 250 patients to as high as 600 patients. Almost never will you see more than 600 patients for a provider with this type of model. So it is, some of you may be thinking, gosh, that sounds great. It's going to be more time. I can call my doctor and they'll be able to get on the phone with me. They're going to answer my questions. They're going to get to my emails. And if you call the office, you will see your provider and not get shuffled around to whoever has openings. Um, so that all sounds great. The downside is, it is tough, honestly, on the medical system for everybody. But, talking from a public health standpoint, which is one of my interests as well, this is a tough model for public health because if every nurse practitioner, PA, and doctor limited to only 500 patients, instead of 2,000, then if you do the math, you need four times as many doctors and nurse practitioners to be able to see everybody. So that is not really a sustainable model. There is part of, I get the question all the time, why is this happening? And is it because nobody wants to do it? And actually, that's completely wrong. It is harder to get into medical school right now than it ever has. You have to have basically near perfect scores, four O's in college, and perfect scores on your MCATs to get in. It's so there are enough people wanting to do it. There's basically not enough medical schools to have handled the increase in population. But that's a whole nother topic. So the this type of model has grown, and there are many different iterations of a what we can call a direct primary care. John had used the words concierge medicine. Sometimes it's called concierge medicine or membership medicine or direct primary care. And if you do investigations into your area wherever you live, you'll see that there can be quite a few different versions. For example, one of them might be where there is a very small monthly membership fee but then you pay for each visit you go to. So that visit might be, $50. And so the more times you go, the more payments that you have that way. And they might then also charge separately for a EKG or a strep test or urinalysis or within that office. And then there are many models where they take a smaller fee and but then have we'll say but then also collect from your insurance, so you still have your physicals, you still have all your visits, you will have your co-pays for those visits using your insurance, but you might pay a small amount to be part of that practice, and in turn they can keep their panel smaller. Then there'll be a slightly above that, there's some national organizations that are concierge medicine where you pay a monthly amount and you get a free executive type physical once a year. I don't really want to say free because it's included in that monthly or yearly membership. But then every visit they do bill your insurance for those visits. And then there's sort of the no insurance at all type market. That's what we're doing here in our practice, where we have a monthly membership fee, and there is no copays, we don't bill insurance. And whether you come twice a year or 10 times a year, it's the same monthly fee, almost like having a season's pass at a ski mountain for those in the ski country on the phone call. The
Okay.
and that makes things much simpler for us, and it allows us to have a smaller overall panel of patients.
And how does you mentioned that a couple of the models integrate with insurance, yours doesn't.
Yes.
Are many of your patients do they have other providers that they go to, and including seeing you, or are you really the first person they go to, and then if they need additional help, you'll refer them to someone else?
So yeah, so the because I have a little bit more time here, there are things that there are more that I have time to be able to do here, and we can bring people in. When we have a lot of time pressures and overloaded panels, might sometimes be more likely to say, okay, we're just going to refer you to see orthopedics for that sore knee. Um, but we do definitely use specialists. You know, my patients, especially the older you get or more complex your care, you might still have a kidney specialist or a cardiologist. We refer out obviously for colonoscopies for your gastroenterologist, and so we still refer out to the specialists when needed.
Okay, but most people are just you're the primary person.
Correct.
Anything that happens, they're going through you. They're not like keeping a other relationship with another entity that they might have been going to before, in addition to you.
Yeah, so we would be serving as a primary care provider for
Okay.
almost all of our patients. There is, and this again depends upon whether you choose a hybrid model or a full no insurance model like what we do here, is that it sometimes depends on insurance. For the model that we're doing here, if you have Medicaid or Medicare or a PPO or something called the EPO or POS, there's lots of different models that we work very well with that. If, John were to come to see me and I need to order an MRI, I can order MRI wherever, whether it's an independent center or one of the local hospitals, if I referred you somewhere else. Where it becomes a little bit tricky, and it can be tricky in New Hampshire specifically, is that this type of model does not always work well with an HMO. So HMOs, health maintenance organizations, most of them do mandate that you have a primary care provider that is in their network, and you can't get a referral to a specialist unless the provider's in their network. So if they were to come to me and I want to say send them to physical therapy or send them to a cardiologist, they might not necessarily accept that referral. So that becomes a challenge, especially in the Seacoast area, because my understanding is currently on the exchange or the Affordable Care Act, the only options that are available are HMOs. So that can be challenging for some folks. Whereas in some of the hybrid models where they are taking full insurance and can be credentialed through your insurance company, sometimes may work better.
Okay. And in all cases, there's some sort of monthly fee that's being paid to the direct primary care organization and all the models you mentioned.
Yes, there is. I know there was a local physician not that long ago who has since retired, who I believe charged $250 just once a year and then did all insurance. And that was a way that he was able to keep the size of the panel at a much more reasonable level and provide a better level of service. But most of the others would be a monthly membership fee.
Okay. And you started this 5 months ago. How did you build your practice from zero to whatever it is now? And what is the typical person that's working in this direct primary care model with you? Or is there no, like typical person? Is it a range of everybody?
It is pretty much a range of everybody. It is so hard to say a typical person. I have been practicing him here for right here in Stratham for 19 years. So I didn't have to do much as much as far as the advertising type thing. Most of it be word of mouth, or even a lot of my former patients in my with my previous practice have followed me over to this model. The typical patient is that's a great question, John. The typical patient is um, not what a lot of people might expect. Some people might say, "Oh gosh, this is just something that somebody with a lot of means or funds or a fairly rich person is going to do," and there's definitely some of that. But there's also a lot of people that just are been frustrated with the current system, and they maybe had a problem and they couldn't reach their primary care, they couldn't get through the phones, and they couldn't get an appointment. And for them, they may say, well, $200 a month, that's cheaper than my cable bill, and I really want to be able to get in when I'm getting in. And so I have a lot of people who uh, may not have a lot of financial means. That's one class of people. Then we also have people that travel. There are people who might say, well, I have a house in Florida and I'm there for 3 months a year, and I want to be able to get somebody on the phone when I need to, or they travel for business. I have somebody who's always traveling and for their particular business. And so whatever city they're in, they know that they can get us on the phone and I'm going to email them back or talk to them that day. Um, we also have some people who do this who have really high deductible insurances. They may have a $10,000 deductible, so they have insurance for the catastrophic type things, big ER visits, cancers, surgeries. But if they pay their $200 a month, they know that their physical and their visits, or if they need a quick visit for a strep test or a COVID test, or that that's all covered and they don't have to pay a bill each time they're going to a provider. So there is, so that's a fairly good variety, I guess, if I answered that well enough.
No, you did. And is it all age ranges too? Like, what's the youngest person you have, and what's the oldest person you have?
So the youngest person that I would have is in my practice right now is 23. I do take care of everything above 18. As a family physician, I'm board certified to take care of all ages from infants on up. But there wouldn't be a lot of children in this practice. And my personal feeling is I wouldn't be able to have enough children to really keep my skills really strong, where I did for the last 19 years take care of children. We wouldn't do enough of that here. And then you really want to be able to stock all the different vaccines. As many people on the line would know, there are lots of different vaccines that are available and recommended for kids. And those are very expensive vaccine refrigerators. And to keep everything stocked, and it can be challenging. There are at least two that I know of this type of direct primary care model that have four that are pediatricians, one in Portsmouth and one in Epping, that have both great reputations. So for those who might be looking for that kind of model as well, they have a child who might have be very high needs, or you have parents who are have very difficult work schedules, and to get somebody to their doctor when their kid is sick is really hard, and they know that they can be called and say, "Hey, I need to come in at 2 o'clock today," and that provider may be able to say, "Come on down." That can be really worth it for some. My partner is also an internal medicine provider, meaning she's board certified for adults. So it didn't really make sense to take care of children in our practice here.
Okay. And can you talk about the typical experience for someone? So they sign up with your direct primary care practice. From that point forward, they're paying the monthly fee. What does the experience look like for them, like in a given year?
So that's quite a variable experience as well. I mean, I have had people who sign up, and I've had my first visit with them in October, and they are great. Everything's doing wonderful. Their labs were all good. Their blood pressure's good. We make sure they're up to date in colon cancer screening, breast cancer screening, vaccines, and everything's good. And they can come back in 6 months to a year. Certainly, we're available if they're having sick visits. And I've had a couple people where they're going through some pretty significant medical conditions right now. And I think there's one person that I've had close to 20 encounters with in just the 5 months that I've been here. So it really can be a variety in where they are in their stage of what their chronic conditions are, or if they've had an acute medical problem. So kind of like using any kind of insurance, whether it be car insurance, homeowner insurance, there are some that are signed up but never using it, and then there are other people that end up being heavy users if whatever's going on in their lives.
And you're doing everyone that signs up, you're doing a physical for them. You're doing a blood test and other tests at that beginning point of the relationship.
Yes, and so that is it. Well, it depends. We'll do sometimes we might just do like they may come here and say, "Well, I just had a full physical and full lab work a month ago with my provider, and they've just retired, and I'm signing up." So we'll have a an appointment to get them established, get all their records, collect their colonoscopy, mammograms, blood tests, review them. But we might not necessarily do a physical or repeat the blood work if it had just been done.
Okay.
And that, I mean, that is pretty universal. I mentioned lots of different styles of membership or concierge type medicine. And one of the things that you'll find fairly universal is a longer physical, truly a look on your ears, check your lymph nodes, mouth, do the whole head to toe skin exam, um, head to toe exam, which is sometimes missing in uh, regular um, medicine these
I don't know.
days,
Or
traditional medicine.
sped through so fast. You don't know how they're doing it.
So I don't know if I've met any different of the concierge membership type physicians or that are not doing at least an hour for their physical or yearly health maintenance exams.
And how do people get in touch with you when they need to talk to you for whatever medical thing do they have your cell phone? Do they call a main line and the receptionist picks up? How does it work in terms of like being able to reach out to you when they have a problem?
So that is something that people would want to, if they were looking at this type of medicine, they'd want to interview their provider and find out how they do that because that does vary quite a bit. There are some bigger membership model groups that I have seen where they do have a call service so that if you call anytime that it does kind of go to service, but then they can directly contact the physician when needed. And then there are the tiny practices like ours where it's just myself and Dr. Jennifer Carter. And we use people can call here anytime up to 5 p.m. And after 5 p.m., they get a voicemail that says, press one if you need Dr. Carter, press two if you need Dr. Keenan. And if they press two, then it goes to a Comcast business app that I have and pings me and also goes to my email to get pinged. There are providers. We don't do text messaging here, but there are many uh, membership model physicians who do text messaging, and some who just do direct cell phone calls. So
So,
that'll be quite variable.
okay. But they have some way of reaching out to you,
Yes,
whether it be through any of those methods that you said, and even after hours, where they can reach you through the service that you have.
correct. Yeah. And that's one of the things that where people are looking for this type of model that often is something that they're feeling they're getting their value for if they're being able to get to you if they need to in emergency after hours.
And do you have any addition at the practice that you're working at? Do you have any supporting staff besides you and Jennifer, or is it just the two doctors?
We have two doctors, we have an RN, and we have two front desk staff. And one of the front desk staff and our nurse are both phlebotomists. So we do the draw the blood in our office and then send it out to LabCorp. And different practices will usually include different type of membership practices will include that type of service as well. There are many different labs out there that will we can send to like the Cleveland Heart Lab, Boston Heart Labs. We tend to use LabCorp because there's lots of draw stations around here. Plus, we do the blood draws in our office for that.
And that's all part of the monthly fee.
Correct. Now the we draw the blood here because it's right now there's a shortage of phlebotomists in the area, and so some of the lines at labs are getting pretty long. So we'd set up an appointment here, whether it's 7:30, 8, 9 o'clock, or if it's not fasting, it can certainly even be in the afternoon. We send our blood to LabCorp, so that's included, but then LabCorp would bill that person's insurance. We do have some patients here who have no insurance, and so we actually have a uh, contract and an account with LabCorp that significantly discounts the cost of those labs quite a bit. And that's so we can basically, LabCorp um, will take the blood, do the testing, and they bill us. And that's how they kind of save on their end by not having to bill patients and wait for collections. They just automatically bill our account, and then we pass that on to the patients. But again, it's probably about a fifth of what the regular costs are.
Okay, so there is some ancillary costs in addition to the monthly fee that either is getting billed to insurance or the patient is paying out of pocket based on whatever it costs you. You're just passing that cost onto the
Correct.
patient.
So when it comes to labs, that would be the only situation where we would sort of kind of pay it for them and then charge. But the vast majority of people are going to still have health insurance. So if you have an MRI or a CAT scan, or if you had a cancer diagnosis, seeing an oncologist, cardiologist, you get admitted to the hospital, surgery, all that stuff would still be through your insurance. It's just typically what is done in our offices is not charged.
Okay. And how do you mentioned before there's a wide range of patient load. Is that the term you used? In terms of
Patient
like the
panel for number of
patient
patients.
panel. Yeah,
Yeah.
sorry. How do you determine that? You said some have 200, some have 600. How do you come up with that number personally? And are you able to do you have to take everyone that applies to be part of your panel, or can you say, no, that's not a good fit for us?
Those, yeah, excellent questions. So the panel size, I think, really depends on uh, what that provider is looking for as far as workload. For me, a lot of it is going to depend upon access. I mean, I want to be able to see people same day. If I get to a point where I can't see people same day, then their value is not there for the patient. And if I were the patient, I wouldn't sign up for that practice. That's part of the main process. So it is some of it depends upon acuity. I have in this particular area have done a lot of geriatric work. So I do all ages, but I've was the medical director of Riverwood's continuing care retirement community for 11 years. So I'm well known in that particular area, and I have a lot of patients at Riverwoods. And when you have a larger percentage of people over age, say 70, 75, they have more visits per year, more medications. So we track our availability and we track the average age of the patients, and that will help determine how many patients. Like for example, I had started this practice with setting my number that it'll likely be 400 just from my various research and what I've done, but have already changed that down to 340 based on the average age of my population and the needs of the patients that I have. I feel like 400 will end up being too much. My partner's kept it closer to 300. She doesn't have as old of an age group as I do, but she has a very big interest in women's health, hormone therapy, and I do a lot of that myself, and I enjoy having her as a resource because she's really very well educated on menopausal treatments. Um, so her age group is less. So each patient she doesn't have an average of her patients coming quite as often as I do, if that makes sense. Um,
Did people price that differently because the occurrence of them contacting you or their needs are higher?
we don't based on that. Again, that could vary quite a bit if people are interested in this type of practice and they shop around, you'll see some different expenses. Like I think that one of the other providers in town, we charge $200 a month for everybody under 70, and then above 70 is 265. I think one of the other providers charges maybe 150 for her 20 and 30-year-olds, and then above 40 it's 250 a month, but then above 70 it might be 300. So there's different amounts based on age. I do not charge based on their medical complexity. I mean, I did actually have that exact question today from a patient who was over 70 who says, I'm super healthy and not any medicines. Can I get a lower rate? But it's kind of like in insurance. It's hard to do that. I do have people who are 40 who are high utilizers of the care and people above 70 who are healthier. But I don't, if somebody's been super healthy and only needs 2 visits a year and then suddenly something happens and they're needing very frequent visits, I wouldn't go to them and say, we have to charge you more. It's still the same amount that we do based on your age, which is arbitrary, for sure.
Well, it's probably easier to do that than usage, basing on usage or
Yeah.
pricing it on usage.
Yeah. And that also, again, we are a bricks and mortar, meaning we have an office here. People come to the office. I do go to do nursing home rounds at Riverwoods for my patients who are in the skilled nursing section there. But there are much different levels of it's not necessarily around here, but in some of the bigger cities of concierge medicine where people may say, I'm only going to have 50 patients and I will charge $25,000 a year, and they will go to your house and see you. And if you go to the hospital, they will travel to the hospital and sit with you in the hospital. And so they're very, I don't know anybody who's ever done that, but you can see that there are, if you look on the web and stuff, there are different types of concierge medicine that go even that far.
And you mentioned people go to, I mean, you're going to Riverwoods, so
Mhm.
clearly you're getting out of the office and meeting people where they are. Is that the only time that you'll meet people in person? Do you go to anyone else's house or some other location to meet with them?
I don't have any currently that are necessarily signed up for only home care, But certainly, if one of my patients had a diagnosis of a cancer and if they end up being on hospice, I would go to their homes. So that is certainly something that I would do. As far as a regular portion of everyday care, that wouldn't really be very easy to do because it might take half an hour to leave my office, get to their house, see them in half an hour. So you might end up being only be able to pay attention to one patient an entire half day.
Hmm.
So wouldn't be able to do that and still maintain access here in the office. But certainly there will be times when I imagine that that would come up and be appropriate.
And does when someone's coming to your office, does it feel like they're going to a doctor's office? I mean, looking in the background, I see you have a lab coat and stethoscope there. Is it is the look and feel of where you currently are the same as like a normal doctor's office?
I think you're going to see a quite a variety of that too. I mean, this is my personal little just office that's just loaded with computer screens and papers and charts. So nothing fancy in here. But as far as our we did renovate our office space when we first moved into here, and ironically, the I was actually in this exact same office in 2006 through 2019, and then we moved when we got a lot of other new providers, including your wife Jane. We moved to a new building in the back here in Stratham that was a much bigger office. We had 8 providers, so didn't expect it, but here I am back in my original office, but it doesn't look anything like my previous office at all. It's all new. The my partner here is likes to get fun with her wallpaper, and so we have some pretty funky, including some alien wallpaper, and yeah, so it is a little bit more decorative, and I guess with this kind of business, you are trying to cater a little bit more towards the aesthetics of the office as well. So it does look a little bit different than what I've been used to in the past 20 years.
That's funny. You made a complete circle in
Yeah,
20 years.
yeah.
So you didn't go far. So people that
No.
followed you from one practice to the other don't have aren't getting lost.
No, they're coming in this office and saying like, "Oh, wow, this doesn't look like anything like it used to." So,
Okay. So about like the cost. So we talked about the monthly fee. You're basing it on age, and the lowest monthly charge is 200. Is that what you said?
correct. 200 a month is what we do up to age 70 and $265 a month after that. And I
Okay.
think if you look around, again, there are various different other providers in the area. You'll see little tweaks, but fairly similar, depending on, again, if they're more of a hybrid model, if they take insurance or don't take insurance.
Okay. And when someone signs up for you, is there a minimum period that they have to be a member of your group?
No, that's a good question. And that may also vary depending on various practices wherever people may look into this. We do a higher fee the very first month. So we do $350 the first month, and that includes gathering all your records, whether it be from Atlantic Digestive Specialists or in core gastroenterology or Appledore, Wentworth Douglas Health Partners, wherever their doctors may have been or specialists may be, we work time to get all the records and get them loaded in and review all those records and then do the standard monthly fee after that first month. And but we feel that likely when people come in that this they're going to be very happy with their experience and stay, but we don't want yearly commitments if they don't feel like this is the right thing for them, then they can go elsewhere. Or if they, finances change. If people say, this is something that's really of value to me and I really want to do this, but in 6 months later, there's a big job change, there's a loss of a job, and we do not hold them to any yearly commitments. So it's basically month to month.
Okay. And that's just paid electronically. You're
Yeah,
not, people aren't sending checks into you guys every month.
so that is that again, depending on where you might go, that's something a question you can certainly ask that office. The way we do it is we have used the checking account number and routing number, and it's just automatic billing. We
Yes,
don't get
yeah.
involved with credit cards.
Okay. How do you think that this model that you're working in now, you've kind of alluded to it before, but how do you think it compares in the health and long-term health of a patient versus the traditional healthcare model that you came from?
That will depend upon your particular provider and that you have because you're going to see a great variety of levels of care. You may have a doctor who always runs on time, but is limited as far as how much they're going to let you do, or a nurse practitioner or a PA, or you may be in an office where different there's a high turnover and people are leaving, and so you have, it says every 2 years you have a new provider, and that can be frustrating. So where we um, where we have the benefit is that you get to see your own provider, and except for maybe the 3, 4 weeks a year that I'm out of town, then you would see me. So that's where some people find the benefit. And I think that more and more people are becoming frustrated with the current systems because there has been more turnover in primary care. They said, I had the same doctor for 15 years, and now in the past 5 years, I've had five different people. And so I think that's where some of the market pressure is pushing towards this type of practice. And that is one of the most common reasons that I hear coming here. If I were to say, why are people choosing this? Some of it's access because of their travel, and some of it's just, I want to be able to have the same provider. And if something happens, I want to be able to go to the provider that knows me. So that's a common theme. I don't know if I answered that whole question or not.
Yeah, I mean they're from their perspective, they're developing a relationship with you
Yes,
and that's important to them. Do you think the long-term health outcome is any different between the two models?
that was the other part of your question. The the studies do show that it does save money. Studies have shown that people, if they have the access and utilization, that they end up using urgent cares and ERs less. And if they pick up things at an earlier stage, that might mean less overall hospitalizations. So it has been shown because when these models first started about 30 years ago, insurances became very suspect and were kind of pushing back on some of the membership models, uh, but they thought that maybe they were going to cost more money. Like, oh, you're going to go to this DPC doctor, and they're going to end up ordering more tests, more blood tests, more stress tests, more everything. And what they found with those studies was that they actually reduced overall utilization. So the insurance companies don't fight it anymore. In fact, they see it as potentially a cost savings. Except for maybe the
Nice.
HMO situation where, a person is signing up for that particular type of insurance where they have to have an in-network provider, as I mentioned early on.
Yeah, I wonder, are there any direct primary care people that are like working directly for HMOs?
I don't know the answer to that.
Oh. We
Yeah,
got
I mean, go ahead.
oh, I was just going to say we have a few questions. So I was just going to ask
Sure.
those,
Yeah, go ahead.
and then we can continue on. The first is, are the costs completely covered by Medicare? The answer is no, but
So the answer is no. In fact, when people do this particular type of practice, I am actually not a Medicare provider, and we have one of the things we have to have people sign by Medicare rules is an opt out, so that people are aware that we do not take Medicare nor bill Medicare. People would obviously have Medicare. If I saw somebody with Medicare today and I sent them for a colonoscopy or to get the blood work, Medicare would still cover all of that part of it. Um, but no, we do not take Medicare here. Now, there are some of the other, as I mentioned before, the hybrid type models where they would you would pay a monthly fee, but you would also, and maybe they would do a free physical. And with Medicare and most insurances, you can't charge for something if it's covered by insurance. So, like in Medicare, if we have any Medicare recipients on this call,
it's quite a few.
Medicare does not cover physical, and that's one of the things that's been true ever since. I don't remember the exact year. I don't know why. I remember it was George Bush the second that actually it was that time when Medicare used not to cover any physicals, but then they developed what they call Medicare Wellness. But that's really a system of questionnaires and preventive, talking about colonoscopies and vaccines and your shingles vaccine and depression questionnaires and memory testing, but doesn't actually require a stethoscope on your chest at all. Um, but Medicare doesn't cover physical. So the hybrid models can get away with saying we're charging and you're getting and maybe an executive physical, this hour and a half long physical, and that's outside of Medicare. But then all your other visits, if you follow up for your blood pressure or anything else, they can bill Medicare for those, and you might just have your copay for those visits.
Okay. So Medicare not covered. This one's specific to your practice. Are there DPCs on the seacoast of New Hampshire who are taking new patients? Since you limit the number of patients, are you at capacity?
I am not at capacity. The We are growing slowly, which is good because if I mentioned the number 340 before, 350 depending if I had all of them on the first day, that actually would have been very much a challenge to be able to kind of get people in a timely fashion. So we are building here. My partner Jennifer Carter is currently full. She's taking a waiting list for those who may want to. I have a roughly 260 people, so I still am taking on, and I'll probably stop at again 340 or 350, depending on the age and the acuity, meaning how what my openings are, and that might even could potentially stop at 340, and then if things start to settle out, and then I have more time, then take on a few more. There are other practices that are open in the Seacoast as well. I'm not
And
too
how did,
familiar with them, but there are other ones open.
s- as I mentioned before, we have people calling from not just the seacoast and
Sure.
not just New Hampshire, but across the country. How do people find providers like yourself? Is it just they go into Google and put direct primary care near me, or what's the best? Is there an organization you can go to that has a list of all of them, or
Yeah, to be honest with you, John, I have not necessarily myself looked through that. I mean the classic name for this type of mile is DPC or Direct Primary Care, and there is an organization called DPC Alliance or Direct Primary Care Alliance. So I think if you Google that, if when maybe when you're doing your part of the talk, if you're going to talk about some of the finances, I can quickly Google it and see if that actually comes up. I have not looked at that, but the I think if the people Googled membership model or DPC near me, then they'll probably pop up for your.
okay. The next question, do you use Epic? I'm assuming the person here is not referring to the ski pass. Do you know what Epic is?
I had the Epic ski pants once, and the lines in Sunapee were so long that I'll never do that again. No, but that being aside, the we do not use Epic. So Epic and this person is probably familiar with that. It's a medical records system. There are many different medical record systems out there, and Epic is considered one of the largest in the nation. And it's very good. Some of the providers who use it get frustrated by it. That I'm sure that John has heard his wife come home with clouds of steam above her head in the last several months, a few times related to Epic. But patients really like it because it has a very good patient experience. Their patient portal, once you get used to it, is very good. People could really track their results and everything. They cater to big organizations. I did kind of look into it here to see what that would be, and the costs were completely outrageous. I would actually have to charge each and every patient an extra $150 a year just to be able to cover that insurance. Is pretty crazy expensive. They don't really um, go for small practices. So we ourselves use something called Practice Fusion, which is perfectly fine from our standpoint here and able to track everything that we need. But it doesn't, the patient portal is not as robust as you would see with some of the bigger organizations like Core Physicians or Wentworth Douglas Hospital. I'm not familiar with the Portsmouth locally, what their patient portal would be. We have the nice thing about the Epic systems is that community providers such as myself can have access to it. I am on staff at Exeter Hospital. I'm not employed by them, but I do have access to Epic, and so I can see patients' reports, labs that are done at Beth Israel, Leahy, Exeter Hospital, as well as Mass General, Wentworth Douglas. The only one I personally don't have access directly into is the Portsmouth Hospital, which is part of a system called HCA.
But you're still able to get people's medical records by asking for them directly from
Ex
providers.
exactly. So people, if they go see a cardiologist, the cardiologist sends us a note. So, or if if somebody's admitted to Portsmouth Hospital, or for your customers that are your clients that are from other cities, their doctor can request those records if they find out somebody's there, get a discharge summary from the hospital.
Okay. And that kind of reminds me, we had talked about this earlier, not on the webinar, but beforehand, about helping your patients that may live part of the year in New England and part of the year in Florida or Arizona. How does that work for you and the patient experience?
So that is actually one of the reasons that some people do sign up for this type of practice is that if they are going to spend 3 months in Florida, 3 months in Arizona, that they would like to be able to call and get somebody on the phone if they have questions or needs and get the refills done without. So we do see some of that. Um, and then certainly they might, let's say if they ended up being hospitalized overnight somewhere in Florida, and there was just one of my patients recently where we had emailed with their provider there and got copies of her blood work and blood counts, and so we know what we need to follow up with when they return back up here.
Okay. You mentioned prescriptions. You're able to obviously write prescriptions for your patients. Is
Yes.
that a
Yeah.
dumb question?
So no, definitely, yep, that's a mandatory thing, and we can write prescriptions anywhere. I mean, I can if one of my patients is in California, I can send a prescription to their California pharmacy. But that's true with anybody within the traditional practices as well, not
Okay.
just limited to us.
All right. Next question. What kind of coordination do you provide with respect to care provided by specialists?
So if people are seeing specialists, the specialist is supposed to send us a note, and almost always they do. Like, so if you went to see a cardiologist for your heart, they would, finish their note and they would send us that, and then we keep track of all of those. So if somebody's coming for their physical, we look back at everything that's happened over the past couple of months or since our last visit, and any specialist notes. And if any cardiologist note that comes in, I read it. So I still have a few of those on my desk today to read if people had seen those type of specialists. If they need help finding a specialist, that is one of the things that is up to us to do. And sometimes that's a piece of cake. I just say, oh, you need to see an orthopedic? Well, here are 5 different ones in this area that can get you in within a couple of days. But then there are some specialties that are really challenging, throughout the nation. The Seacoast, I know here we really do struggle a bit with psychiatry and neurology. Neurology being one of the biggest ones that's in short supply here, but that's sort of a national problem. So we do have a little bit more time in a practice like this to be able to call around and really try to work to get somebody in to for a specialist. Um, we don't have a network, like just because I'm a membership model does not mean the local cardiologist is. So they're not necessarily going to say, give a person, one of my patients, priority over another patient, but I will be writing a letter of introduction. I will be sending all their records to them, and they're more likely to get that. I will email them and coordinate care. So I have more time to be able to email back and forth with that specialist provider and contact them if there's any questions, and sort of advocate on my patient's behalf.
And you don't necessarily have to send it to somebody that's in a certain network or group. You can kind of pick whoever you think is best or has um, time and is qualified.
Exactly. And you just said it, who do I think is the best person for the job, and who is available? I mean, a lot of times there's plenty of good people that we could send it to, but a lot of times it comes down to availability. But we are not locked to any particular provider. I mean, I think we live in a fantastic place for medical care here in the Seacoast, New Hampshire, because we can do almost everything here. We've got a lot of great providers here, but if we don't, we have this fantastic medical city of Boston and Mass General and Beth Israel 50 to 60 minutes away. So if people have something that's big and they have a cancer, almost all of their care can be done here locally, but getting a second opinion in Dana-Farber is very possible. So I think we're fortunate to live in the area that we have when it comes to medical care.
Okay. If people are looking, they go to the DPC Alliance website or they Google direct primary care near me, whatever it is. what do they have? Is there any like charlatans in this business that are just trying to get people's money and not really providing care? Is there anything people need to look out for when they're choosing a provider in this model?
That's a great question. And so I've not heard of any. So as far as any people or um, predatory type companies that are out there, but just about any organization, certainly we do here, we have meet and greets. So people come in, no strings attached. They come in and meet myself, and if they come in this office, chances are they're going to meet 80% of the office staff because two of our three women that work in the front are here two of the three are here every day, and often myself and my partner, Dr. Carter, are here. So you're often coming in and you've met everybody. Anybody who's going to pick up the phone is right there, and so you're hearing about the office. So if people have any questions about our practice, or for anybody that they may choose from, I think just about every DPC or concierge type practice will have free meet and greets. And so I would tell your listeners here to take advantage of that. Meet the people and feel them out and talk to them, and then they could talk to their friends and neighbors. When it comes to medicine, this is a general piece of advice, nothing about the DPC. Really, word of mouth. Talk to your neighbors, talk to your friends, is often the best way to get information. If you were to I'll pick on your wife, Jane. If you were to maybe look up Jane online in her reviews, if she just happened to tell somebody that, she doesn't believe they should be on this certain medicine, a certain narcotic, and no, they shouldn't have testosterone because their testosterone's through the roof already, that person could write a horrible review and make it look like this is not a caring provider. So online reviews tend to be done often by the disgruntled people. So it's not the best way to find out about medical providers.
It sounds like you're talking about Yelp.
Yeah, it's so well. There's so many. There's health grades. I mean, there's others. I mean, if you Google a particular provider, there are so many things I've never even heard of. Different types of organizations that are kind of scam emails that will do that. So really, friends, family, neighbors. It's often some of the better reviews you can get. But take advantage of getting to that particular office and meeting them.
And another question we had is, do you have regular patients in addition to your DPC patients? And I guess you could talk to that in the industry as a whole.
Yeah.
Are people doing other things besides this to supplement their income or fill their time?
Yeah, that's a fantastic question too. I did not mention that before. There are a few hybrid models as well where providers have, and I've met one or two in my kind of research and journey, I suppose, into this over the past several years. There were a few that had done hybrid, sometimes to start off with, where they might say they instead of 2,000 patients, they may only have 800 regular patients and 100 concierge, and those 100 patients have um, preference in the schedule, or they have certain time blocked out in their schedule for those 100 people, where they keep a couple visits open every day if one of those people call, and those people might have their cell phone, but their other patients don't. I always thought that that was kind of a gray area. Just myself, this is my own personal bias. I didn't really like that type of model. And I also didn't, for patients, it didn't seem good to me, but I also, from a provider, it didn't seem like that would be very good because one of the things about me choosing to do this is that, my day to day is much easier. My visits are longer. I can get through them. I get my notes done. I'm not stressed about getting to all my messages because I will have time to get to all my messages tonight before I leave. Um, but if
Depending on
you
how long this webinar goes.
Exactly. But the problem it being that if you have one of those type of hybrid models, you if in my previous model with core physicians, for example, I worked incredibly long, stressful, busy days and rarely stopped for have meals and would work straight. But then when I went home, I was done. I was not on call, except for when it was my turn to be on call, which wasn't that frequently. So you were super busy, but then you were off. In this practice, I'm always on unless I'm on vacation. I'm on, so out of the 365 day or 52 weeks a year, for 48 of those weeks, I'm on. So that's the downside, but the good side is my day to day is easier. So that other model I just talked about didn't seem like that would work very well for the physician because you are working like crazy every day and you're on all the time.
Uh,
And it just seemed odd if like, oh, I'm sorry, this patient gets preference over this particular appointment slot because they're a extra paid patient. They get a like a Disney fast pass or something like that. And it just didn't seem good. But there are those models out there, not in this area that I know of.
but people do just can you have your direct primary care business like you do, and then also work somewhere else providing care at some other organization, or is that not allowed?
That totally depends. I mean, I think that where I was an employee of a local company, Core Physicians before, they wouldn't necessarily say, "Oh, I could also be doing this on the side." But I don't think many people would want to anyway, and I'm not blaming Core for that. I don't think that really matches their kind of business model. It sort of gets kind of gray areas about um, ethics and when you get into that kind of thing. But there are many providers. When I took on this, for example, I was the medical director of Riverwoods. I could have kept that. So that is something where I could have had to answer your question, like a side thing where I was also remained the medical director. But I did want to, as building this practice, make sure I had enough time to do this and I thought that both would just be too challenging, but there's no reason why I could not. I know there are some other even in this area more direct primary care or membership model, concierge model, where they also might be the medical director of a particular organization or a nursing facility. Or maybe
Okay.
do hospital shifts. They could be like a part-time hospitalist and still be able to do this.
Or work at an urgent care or something like that.
Yeah, exactly. Especially when they're building. If they were starting kind of from scratch and it was a slow build, then doing that may make sense for them.
All right. Earlier you had talked about the financial piece of this. You can't bill insurance for the monthly charge that you are charging. Um, we had talked about how it's now with this new tax legislation that was passed earlier in the year, it is allowable to use your health savings account money to pay for direct primary care. So you can take a distribution from an HSA, and that's a qualified medical expense. So there is some benefit there. People have health savings accounts. This would be something they could use that money for. It's also can be included. Not many people itemize their deductions now with the standard deduction being so high, and it's hard to use medical expenses because you have to get over 7.5% of adjusted gross income threshold. But these expenses can also be part of those medical expenses, just from a financial perspective. I know you wanted me to cover that. Um,
Yeah, because I found that kind of confusing myself. So I'm glad we have a financial person to kind of explain that with some of those changes that have um, occurred.
and you mentioned that a lot of people pair this model with a high deductible health plan, which is how you become eligible to make contributions to an HSA. And I think that's a perfect complement. You have this for the normal stuff. And then if there's something catastrophic that you need to use insurance for, yeah, you have the insurance. There is a deductible you have to pay for, but that's only if you need something outside of the services that you're providing. So it is a nice and now with insurance premiums being so expensive, um, this is an option for some people to do. But
I've heard about that becoming a little bit more popular in certain areas of the country too. I don't believe I have any patients in that particular situation now, but where people might have a catastrophic insurance plan where they have a $10,000 deductible, but their employer will put $4,000 a year into their HSA. So if they were to then spend $2,400 on this type of practice a year, that would take care of so much of their medical needs, and just to know that that's there, that would be sort of a way to hopefully avoid, any of those catastrophic events by getting the care that they need. Because otherwise, with a $10,000 deductible, they might say, well, you know what, I can't really afford to get to the doctor. I'm not going to go to the doctor for this little bit of chest discomfort I have because it's probably just heartburn and I'll let it go. And the idea is to try to not have that happen.
Yeah, and that aligns with what you were saying before about long-term health outcomes
Right.
being better in this model. All right, we're right at 7 here. Want to be conscious of everyone's time. I think we got through all the questions. If anyone has any last minute ones, please type those in the question and answer box. We'll get those answered. In the meantime, Tim, you want to just talk briefly about your practice? I'll throw up the website here real quick.
Sure.
So this is
Thanks.
yeah, this is the website for your Seacoast Direct Primary Care practice.
There it is. Yeah, thank you so much. Um, so as I said, we're just uh, three employees and two physicians, so it's just five of us here. So we pick up the phones live. We have good access and availability, and if people are interested in exploring this type of care, we do have meet and greets available if people want to come, and we schedule a half an hour just to come in, meet the office, look over some of the paperwork here, and ask me any particular questions that they have about the practice.
And that's you just click on this button, schedule a free meet and greet appointment.
Yeah, exactly. Or just call the phone number that's at the top, sort of top right there, and sometimes that's even easier.
There's your pricing schedule right there.
Oh, and I haven't
And
even seen that picture. That's a new picture you just put up there. So,
which one? Under membership pricing?
no, the one, yeah, the one there with Dr. Carter sticking her head out the door there.
Okay.
The yeah, the membership pricing one. So,
There's the
so
pictures of the whole group.
exactly, all of us, all five of us, no call centers.
All right. So last question, which I forgot to ask you. We talked earlier about this, the Function Health, Cancer Guard, two things that I've seen online recently of like not really similar to what you're doing, but outside of traditional medicine. The
Yeah,
first being like a blood testing thing where
yeah.
do you have opinions on those?
Sure. And this is it'll be interesting to see what comes of this type of thing. There are more John mentioned Function Health, which is an online, you can order blood testing and you can get like 100 different blood tests and they're really not that expensive in the grand scheme of things. I mean, yes, I think $400, $300 is I don't want to make it sound like that's nothing, but the amount of blood tests you get, whereas in right now, if your family doctor ordered you four different blood tests and you went and had them done at one of the local labs or hospitals, they would probably be almost $400. So this is a massive panel that they're doing. And so people are getting more into that. And I am seeing some patients who have done this function, and then they're bringing them to me. They don't really get, they'll say right on the website, they don't give you an analysis of it. You still need to go to your physician to go over those results. And it's great, people say, but there are a lot of things that aren't necessarily needed. And there can be false positives and false negatives with blood tests. So blood tests are not perfect. Often they're best done in context. And for example, it's very common for men now to say, "Oh, I want to have my testosterone checked." But if they're not having any problems with muscle mass, they're not having a desire with their desire for their partner, their libido is not low, they're not having any erection problems, and I would say you don't want to know your testosterone. If your testosterone is low, it doesn't matter. It matters how it's working. So there are people who say, "Oh, gee, my testosterone level's low. I need to have testosterone injections," but you don't want testosterone injections unless you are having symptoms or problems. So that's where some of these blood tests can lead you down rabbit holes. You can get it can make people very anxious when there are abnormalities, which may be meaningless. There's also now some places which I don't necessarily advise myself, just in my opinion, full body MRIs where you can pay and get your body MRI'd head to toe. But I will say that every one of our bodies has some unusual things in there. We might have cysts in our kidneys that are benign. We have spots in our liver that are benign. We have some little scar tissue in our lungs. And when we find these, they make us worried. Providers worried. They make the patient worried. Then we might do a CAT scan. Maybe that leads to a biopsy. and maybe that biopsy will have harmed the person. So finding some of these things can actually lead to harm. So everything we do in medicine, we really need to think about risk and benefit ratios. There's a side effect to a shingles vaccine, but the benefit far outweighs that. Will we ever have a vaccine against the common cold? Probably not, because there is some inherent risk to a vaccine, and the risk of the cold is so low that why would you take that risk?
Mhm.
So we have to think about that with everything. So when we talk about whole body scanning, there are a lot of benign things. It's not something I would want to do myself. There are some more emerging tests where they're starting to look at more full body cancer markers, where they're actually looking like metabolic and genetic abnormalities, which can increase the chance of picking up some other cancers. And I think we're on the cusp of that being real. Right now, it's not something covered by insurance. There's ones I know we do send out some here if people want it, and that is all a self-pay thing, and that's not inexpensive. And the problem is cancers can start anytime, so it's something you have to do yearly. And for some people, doing a $600 blood test yearly is a lot of money when the chances are it's not going to find anything. But that does have more promise than the full body imaging. So I think the answer to that is there's more to come. When it comes to the various cancer screening, I think that's going to get better and better over time.
And you can do that through blood tests as well. Is that what you're referring to, the cancer screening?
Yes, so there's a blood test out there. The company's, I think it's the Grail testing by Gallery, and then there's a couple others that are their blood tests. And then often within the medical offices now for targeting genetic testing, like if you came to me, John, said you had a really strong family history of colon cancer, breast cancer, prostate cancer. There is some saliva test that can be sent that companies are doing it. That one often is covered by insurance. As long as it's we can document that you have a family history of something, then we can do that type of testing, and that can be a covered test.
Okay, great. Well, thanks for taking that last one.
No
Appreciate it.
problem. Yeah.
All right. Well, thank you, Tim. This has been fantastic. You really gave us a good understanding of what the direct primary care model is, and very knowledgeable with your many years in as being a doctor. So thank you for coming on tonight and discussing this. And if this will be recorded, so if people want to check this out on the website, we'll have it posted in a couple days. And with that, any other final words, Tim?
No. I think this is I get my final words, I guess, would be that this is a fantastic option for some, but it's not necessary for everybody. There are many people that are doing fine in the current traditional system, and this is an expense that they don't need. And if they can take the money and join a gym and get to the gym 3 days a week, that may be the best health decision. So it is a good option for some in the healthcare world, but it's not necessarily for everybody.
And the best way they can figure that out is by talking to a provider and seeing if it's a good fit.
Yeah, exactly. Exactly.
All right, sir. Well, thank you so much,
All
and
right.
I hope
Thank you very
you
much. Appreciate it.
get out of the office at a reasonable time tonight.
All right. Thanks so much. Have a great
All right,
day.
Tim. Take care.
Bye-bye.